Good afternoon, everyone, and welcome. My name is Álvaro Saldaña. I am speaking as a member of the Critical Physiotherapy Network. It's a pleasure to invite you into today's session, which is believed engaged with some of the most pressing epistemological and ethical questions currently facing our profession. We're here to share our ideas, and we are here for share our experience about this topic. In this case, we're going to talk with the Dr. Karime Mescouto. Karime is a physiotherapist from Brazil and currently a postdoctoral associate at Western University in Canada. She's part of the Partnership for the Engagement of People in Pain Research, where her work centers on amplifying the voices and experiences of people living with chronic pain, particularly those in context of marginalization. Thank you, Karim, for your time, and the floor is yours.
Thank you so much, Alvaro, for this lovely introduction. I'll just share my screen here. Okay, hopefully everyone can see that. So thank you so much for having me here, just to present some ideas actually from my PhD. So as Alvaro mentioned, I'm actually from Brazil. I did my undergrad and master's in Brazil. I'll give a little bit of my background. And I'm now doing a postdoctoral role at Western University in Canada. But the ideas here comes actually from my PhD that I did at the University of Queensland. So hopefully from this conversation, I'm really looking forward to some discussions, some thoughts of how the idea of going beyond the biopsychosocial model and thinking critically around this model and beyond resonates or not with you and your practices as well. So just a information. So I think the session was supposed to be an hour and a half, but unfortunately there was some crash of different time zones, so I'll have to go at in 1 hour. So we'll have like 1 hour for this session. So hopefully I'll talk. I usually talk too much, but I think the main idea is to just give space for discussions later on. So before I begin, I just would like to make some acknowledgement of country, of land. I would like to acknowledge the traditional owners and their custodianship of the lands on which we meet. Here today, I'm speaking from João Pessoa, Brazil, the lands of the Potiguaras and Tabajaras. And I just pay my respects to their ancestors and their descendants who continue cultural and spiritual connections to country, and just expand my respect to any First Nations peoples here today. So as I mentioned, I think sometimes it's important, and I really like to put this slide on. It's just, of course, there's a list of things that I've done, but I think we need to know where we came from to understand where we're going and the influences that we have throughout. So these ideas that I came about in my PhD, that it was an entanglement of many different things, and my history and my background comes to this as well. So I'm from Brazil. I did my undergrad, did some postgrad and master's in Brazil. I was a lecturer there, and I moved to Australia to do my PhD, where these ideas and these concepts that I will present today came about and really became part of my work. And which I will continue to consider having in between these two worlds of physiotherapy, health sciences, and sociology, social sciences overall. And now I'm a postdoc researcher. I did a postdoc at the University of Queensland in Australia, and then I moved to Canada to do another postdoc more related to the critical area and environment. So I think also as positionality as researchers, so it was a little bit of my positionality as in a personal historical way. But I think my positionality today as a researcher, I consider myself an emerging critical pain scholar. which means that I challenge and question assumptions, biases, and power structures that shape knowledge production and everyday practices, even as researchers, clinicians, and educators. So I really use research, or try to use research, to address inequalities and social injustice. Personally, I use qualitative methodologies to do so. And in my current role, I'm a postdoc at this Partnership for the Engagement of People in Pain Research. If you're interested, I can share the links after, which we really want to understand patient engagement through a more equity lens. And I'm also the coordinator of this Critical Approaches to Pain Scholarship Research Network. If anyone is interested, we have a website and a LinkedIn page where, similar to the CPN, we also kind of bring together critical pain scholars, as I mentioned, to discuss and to connect about this shared meaning and shared value. So the presentation for today, or the discussion, is around, it is thinking beyond the biopsychosocial model in physiotherapy, but I will use the example of low back pain care, which was the main population, the main focus of my PhD, which I completed in 2023. And I was, again, what I said, between these two worlds of health sciences, physiotherapy, and sociology. And the main aim of my PhD was to really critically explore how low back pain care was enacted in practice and what factors beyond the model require further investigation. And here I kind of bold these two main concepts, critically and enacted. And critical here, it really comes from Foucault's idea to mean critiquing and challenging assumptions of this familiar unchallenged modes of thought and practices. And in the context is the assumption underpinning the biopsychosocial model in physiotherapy, and more specifically in low back pain care. And the enacted one, which I'll go through a little bit more at the end of the presentation, but it comes from philosopher and ethnographer Annie-Marie Moll. And it really highlights how research and clinical practices in this context to bring attention to what is being done in the moment of those practices. What is the materialities? What is going on in the practices, and what type of realities we are producing through those practices? Which aspects, I think one of the most important things, which aspects are being prioritized and which aspects are missing or minimized? And just a spoiler here, the care of people with low back pain, it goes beyond the biopsychosocial model. So this is the whole premise of my PhD. And the interesting thing of a background, I really put that on my thesis, because I think this is really important in terms of confessing. And this is a confession, because before starting my PhD, I've never heard any critique of the model. The model in physiotherapy and in many other professions is thought of as a moral good, as like it comes from the good thing of bringing together the bio, the psycho, the social, thinking of people and conditions in our holistic approach, rather than just focusing on holistic, although I'm not a fan of this word, but it's more on how we can have different dimensions pertaining the things that we do, the conditions that we have. But I've never heard a critique of it before my PhD. So I was really interested once I started to read. I was really surprised to find many critiques of this model in disciplines other than physiotherapy. So we know that the biopsychosocial model is highly influential, and it has been highly influential. Nowadays, I think we have more critiques of it. But in terms of the critiques that are particularly important for this conversation, for my research, was more related to the difficulty to apply it in practice, of why it is so difficult, the lack of a clear theoretical foundation, and an underappreciation of its social aspects, culture, ethics, spirituality, stigma, social identities, and so forth. beyond this model that is not approached by it. So I think today, I'll focus more on the lack of clear theoretical foundation and this underappreciation of its social aspects. And here's a little bit of a warning. I hope to kind of have this more philosophical conversation. It's more of a theoretical, philosophical discussions around this model, around physiotherapy. So I just would like to invite you to put your perhaps philosopher's hat on, or considering this more from the humanities, these concepts of that can help move us beyond these traditional models and think differently. And here's where I start the philosophical discussion, right? So what I argued in my PhD was this need for post-critical approaches to and theories about low back pain care. And the amazing Barbara Gibson is here today. So I took the the name from her work on critical disability physiotherapy. So it's really a little bit intimidating, but it's really to consider, what do I mean if you're not familiar with this post-critical concept? What I mean by post-critical approaches and theories, it's to really foreground the relationship between power and knowledge. Over here, really considering what type of knowledges we prioritize. Why are they being prioritized? By whom they're being prioritized? Because they are connected. This type of knowledge systems are connected to power. Post-critical approaches come from philosophical traditions such as post-structuralism, post-humanism, and etc. So that's why the name of it. And it's really to bring forth, have a clear practical goal for social transformation and a commitment to critique of post-positivism, or this idea that there is a one truth out there that there will be discovered through, a valid scientific evidence. So for example, the biopsychosocial model, we will know which psychological aspects to assess and treat. We will know which social aspects to assess and treat, for example. And it's really a commitment to relational inquiry, or, how people, history, culture, social context, and structures, they all relate. So this is kind of broadly my theoretical underpinning of thinking beyond the biopsychosocial model. And how did I actually use, the research, or what type of methods I use to kind of investigate and use this theoretical underpinnings? So it is actually Patty. Again, I have so many important references here today. So Patty and my primary supervisor, they also developed this, and Barbara, of course, also developed this kind of relational methods of observing people, like having observations of clinical practices. So I observed two clinics in Australia, a multidisciplinary pain clinic and a private physiotherapy clinic, to kind of understand what was going on between clinicians and people with lived experience of low back pain, just to understand the clinical environment, how bodies behaved in the environment. I also had dialogues with clinicians. So from these observations, from these ethnographic observations of clinical practices, I kind of brought back to the clinicians some snippets of interactions to understand from their perspectives what was going on, to really make them reflect on those and challenge those views. If these interactions were going beyond the biopsychosocial model, how, in which ways. We also had a research team made with researchers, but also clinicians and people with lived experience of low back pain, to kind of bring those concepts together. And we also consulted with people with lived experience of low back pain to understand, they were not participants, they were almost consultants. So it's really a participatory approach of multiple groups of people who think the same, or different knowledge systems to really bring together. So that's why I called it relational methods, because they were all related, it was all interconnected. So this was my empirical work. Some of the outputs from that are here, but I think I'll focus more on two of them throughout, it is the critical review, which was a review of the literature, and the final article, that I kind of put everything together, which is the Towards an Ethical Multiplicity in Low Back Pain Care. And what I did, coming back to this philosophical conversation throughout my studies, throughout the output, throughout the research, was thinking with concepts. So this is from Jackson and Maze, understanding that concepts, they're active. They're not mere concepts with shallow meaning. They have history. They can really help you see what's going on in the world in different ways. So they call it a process-oriented methodology. So I didn't use grand theories or specific methodology, qualitative methodology, but I use concepts to help me to think differently. So here I'll just share how my thinking with Foucault's concept of power and discourse really helped me to see the interactions and some of my approaches differently. So for Foucault, power is everywhere, right? So it's fluid. Power is not something that certain people or institutions hold, how it could be seen. It is actually pervasive in everyday life. Power is deeply connected, and because of that, it's deeply connected and embodied in knowledge and how we come to understand and accept certain ways of thinking and acting. In the example here, how we, that idea of accepting and understanding without even challenging the biopsychosocial model, for example. And another concept is the discourse. And discourse here goes beyond just this conversational exchange. It really includes systems of thoughts, beliefs, and practices that construct realities. So using this kind of both concepts, especially discourse, I did a critical review, me and my team, of the biopsychosocial model of low back pain care, especially in this area where there was like physiotherapy, but also beyond qualitative, quantitative research. So I did like a systematic search of the literature to really understand what are the discourses, what knowledge systems are being portrayed about the biopsychosocial model in low back pain care. And the findings were really interesting and surprising. So this was the basis of my PhD, to really kind of what we've noticed from the selected and included articles is that they were mentioning that they were doing a biopsychosocial approach, but they were actually conflating it with the biomedical model. They were still focusing on very biomedical aspects of low back pain care. They included at times these more psychological aspects, such as cognition, behavior, yellow flags, and report, but that could be quite limited in terms of the whole approach to psychology, for example. There was some brief and occasional social underpinnings, not a lot, in comparison to the psychological part, for example. And there was almost none of those expanded aspects of care, such as power, such as culture, power dynamics, institutional power dynamics, and etc. And that was really interesting, because if you consider the premise of the biopsychosocial model, it is to incorporate biopsychosocial, but the social is actually was actually sidelined in those articles, which you can connect to physiotherapy. Are we really, as a profession, saying that we're taking a biopsychosocial approach to physiotherapy, or are we still perpetuating these more biomedical discourses with hints of psychology? And even less hints of social, of these broader aspects of care. So that was, a review of the literature. And because of that, I really wanted to see if in practice, the same thing was happening. So this other study was looking at the empirical data at the private physiotherapy practice. And it was really interesting how it holds similar thinking with the critical review. So in practice, what we've noticed was that, physiotherapists still hold that dominance of biomedical norms, thinking of fixing people's bodies. There was a lot of familiarity with these biomedical norms, and from everyone, from patients, from physiotherapists, from even within the physical space, with structures of the spine, of pictures on the walls that portray like trigger points and etc. So it was very pervasive in the physical environment and in people's attitudes. And physiotherapist professional identity, follow these biomedical norms, and institutions as well, how care was organized, how this private practice organized care in a very simple way. People only had 5 sessions and, needed to be quick, get in, get out kind of thing. So that was, something that it was perpetuated in practice. But we also, if we think about power, it can be both, constructive, but destructive, but also constructive. And in this type of resistance, and we look at, resistance towards attention to broader aspects of care, pertaining social stigma, and when physiotherapists attended to social stigma, emotions, when they had further collaboration with patients in their decision-making in a very open way, and when they challenge usual biomedical discourses and focus on this more emotions and etc. So we really saw resistance in practice through micro actions, holding silence, not speaking all the time, really pausing, giving space, providing more therapeutic touch, having a slower pace, time flexibility that allowed what we call the psychosocial plus aspects of practice to come up. So these two examples kind of, bring how physiotherapy as a profession, we kind of try to say that we are having a multidimensional approach, but we are caught up into this biomedical norms still. So this is just some reflexive questions. I'll have a few of them throughout. But what assumptions can be challenged, or perhaps that you are already challenging in your own practice, being either research, clinical, education practices, to enhance equitable care? Because that's the main point as well, is to have a true multidimensional approach to really considering power and knowledge and how knowledge systems work. It is to make sure that everyone belongs, that our care, our educational practices, our profession actually approaches and reaches everyone. So this is just some provocation. And finally, another the other concepts that really helped me expand my thinking beyond the biopsychosocial model was enactment, which I already kind of mentioned, multiplicity, and nomadic ethics, which they are all interconnected. So I'll focus more on the multiplicity one, which is I really like this concept. It really helped me to consider my practice as a researcher, as a clinician, and as an educator in different ways. And I'm not putting forth that, we need to move from the biopsychosocial model to a multiplicity concept. That's not it. It's just one out of many concepts that can help and can assist us to think broadly and differently. So the concept of multiplicity comes, as I mentioned, from Anne Marie Moll in her book, The Body Multiple. And So she really traces the management of atherosclerosis in a Dutch hospital system. So she takes, she observes how atherosclerosis moves, how people with atherosclerosis move, but also the disease, the condition. She's really interested in the multiplicity of the condition. So Mo shows how atherosclerosis is actually made multiple through healthcare practices. So through the practices, reality is made multiple. Atherosclerosis is not just one thing. How it moves throughout the hospital with different interactions, it becomes something else every time. So multiple forms of the same disease, of the same body, are manifested through different practices. So that's why she mentions that in the hospital, the body, singular, is multiple, plural. So it's not one condition. It's multiple conditions within the same condition. That makes sense. So we're talking about the multiplicity of reality here. I'll give some examples. So Mo discusses this multiplicity into different ways, that the body, that it's meant to be singular, or perhaps from the biopsychosocial model is fragmented into this trifecta of biopsychosocial, right? So we're people who have like these 3 dimensions, for example, and in multiplicity is actually the body who is thought of as singular is actually multiple with multiple parts. So it's not about, but it's important to say that it's not about plurality or group or things, occurrences, but rather about the contradiction as well. It's not something that comes together easily. You have contradictions, you have tensions around this multiplicity as well. So atherosclerosis is the thickening of a vessel wall seen through a microscope, for example, in the pathology room. It is a patient, but at the same time, it is a patient discussing with a clinician the social implications of not being able to walk without pain, and these 2 different, but it seems to be very, very different atherosclerosis are not entirely separate, nor are they exactly the same thing. They might come together in patient notes, but are given different priorities at different times. And they come up in how decisions are made. So multiplicity here, when we think of the multiplicity of multiple realities of the same thing, right? Here I'm considering, of course, low back pain, but if we make an analogy of physiotherapy, what physiotherapy really is within this biopsychosocial model, is physiotherapy actually only related to biopsychosocial, or what are we as a profession, right? So making just this parallel. So as an analytic or reflexive tool, this way of looking at a condition, at a profession, etc., allows us to understand what we do as heterogeneous. It is complex, is contradictory, is ambiguous, but is also very relational. It is more than a plurality or assemblage of things. It is this constant tension between realities that are being coming together at the same time. And it really exposes hidden dimensions of practice, right? Emotions, power relations, cultural objects, and so forth. So perhaps just conscious of time, I'll just move from this example. But this is just, I was just going to share this example of a excerpt from the pain clinic, like an interaction from a physio and a patient. And thinking with multiplicity, we can really tease out, many forms of one small part of an interaction. One small part of an interaction can mean many things. It can actually expose many hidden dimensions of care. So I'm just gonna move, because of the time, but it's just for us to consider that even small moments, many multiple things are happening at the same time, and consciously or unconsciously, we're because of norms, perhaps we're moving towards certain preferences in our practices, either being clinicians or researchers. We tend to focus more on certain things and not others. So perhaps just the final one. So the physio asks about a knee exercise, right, that she prescribed. He was giving for rehab and inquiries if they included squats. This body don't do squats. That's the answer of the patient. So if this body don't do squats, what is happening there? Is it pain related to trauma? Is it cultural practices that perhaps the movement doesn't allow you to be in that particular position? Or it's just a simple unwillingness to perform the exercise, or just the patient really making a clear point that he is resisting that exercise that he doesn't like. So there are many, many things that are happening. It's not only about, for example, if in a more biomedical way, it's the patient being difficult or, non-compliant, for example. So that's just a small here. And multiplicity also brings attention to the physical environment. How is the physical environment set up? Well, it's not only about the humans in the interaction, it's about the non-humans as well, right? This materiality of our daily lives. So where's from my research, where is the computer positioned? Is the computer actually being a barrier of physical barrier of the interaction? It is, bringing more attention to a clinician making notes than looking at the patient and paying attention to patients' stories and etc. The size, so that was one of the example. The other example is the size of the chairs that we've noticed in some waiting rooms. Some waiting rooms only had one size of chair, so that kind of implies that one type of body is able to sit on those chairs. And we had other places where the chairs, we had bigger chairs, small chairs to really accommodate people with bigger or smaller bodies. So that was something interesting to notice of the physical environment and how the physical environment also perpetuates certain assumptions about people's bodies and then accommodate people's bodies differently. So again, some reflection here. What are examples of seemingly benign practices within your interactions with patients or your interactions with students or your interactions with researchers or participants that might be seen differently? How can multiplicity help in this process as well? So this is just the final thing that I would like to share is the other article that I think Patty kindly shared on the chat. Is so the critical review one was the first, almost the opening of my PhD to really reflect on the biopsychosocial model. So that was non-empirical review of the literature, and this one was kind of putting everything together to what I call going towards this ethical multiplicity in low back pain care and practicing beyond the biopsychosocial model. So I use this, two concepts of multiplicity and Mohs multiplicity, and another philosopher, Rosie Brodotti, nomadic ethics, to think about how can these multiple beings, these multiple aspects in practices be more ethical. And these are very connected to becoming, right? Is a commitment to becoming, is this continual process of, not becoming something in particular, but really considering that practices are never finished, that they are always changing, that we're always shifting. But at the same time, these practices have a deep sensibility to multiple others. So that's why this ethical commitment to, okay, they're changing, they're fluid, but there is this commitment to have a deep sensibility to multiple others, being not humans and also non-humans. And in this process of looking at what was happening in practice, what I, you know, what we saw was that clinical physical spaces are active. They enact or they make low back pain care multiple, right? They make care multiple. They can bring attention to dysfunctions or welcome imperfections, tears, laughter, and joy. That is all also part of care. That is also part of physiotherapy, for example, and healthcare. So we call this becoming more than sterile environment. It's not a space that people just come in, get out, do their exercises for specific strengthening things, or just to focus on the joints and the muscles, but it's much more than that. The ethical multiplicity of low back pain care and going beyond this idea of only this trifecta of biopsychosocial is accounting for the diverse and multiple physical bodies with low back pain. It is this sense of becoming minoritarian, challenging differences between patients and clinicians, or between self and others. It's more of that relational approach to care. Becoming minoritarian, it involves considering power relations in this multiplicity, really acting towards better connectedness and belonging. And also, it's through these clinical actions, we saw how we need to be more fluid in considering our disciplines. Since the body is not and should not be fragmented into these different dimensions, our approach should not also be fragmented. It's not about going beyond your scope of practice, but really considering that if the body is not biopsychosocial, it's multiple, and multiple things happen in practice. We need to be, considerate, ethical, and reactive on responsive in how we approach that body with multiple needs. Because low back pain is multiple, care is multiple, it involves physical, material, mental, social dimensions. It eventually will pass through disciplinary boundaries as well. So this multiple becomings is just, it really considers all the ways of looking at different knowledge systems about the body, about reality, about how reality is produced and how we produce reality. And it really considers how knowledge, reality, ethics, they are interconnected, which provides a better understanding of how places, objects, emotions, power, bodies, and professions, they come together in this messiness. So that's why I put this. It's really messy, really confusing, but it is also beautiful for us to kind of incorporate this messiness into our life and make it more approachable and more productive. So yeah, I think I'm close to the end. So I really, in this, although I'm talking about low back pain care, I'm really considering physiotherapy and how physiotherapy can also embrace this messiness. It can be difficult to apply in practice, but it also kind of offers a practical application in which directions from from this theoretical place, from this values base, it forges this strong theoretical foundation to understand better all these conflicting knowledge systems that come together in practices, and to attend to social and other broader aspects of care in more effective ways. So that's why in my thesis, I argued how the biopsychosocial model is not working as it's supposed to be. This multidimensional approach is not, this trifecta of biopsychosocial is not enough. And care, either being low back pain care, even being physiotherapy, it's multiple. It has this multiplicity. These and all the multiple aspects, they do not have like fixed rigid limits, but they're permeable. They can change, and they are constantly changing in practice, which requires us, researchers, educators, clinicians, to attend to this fluidity and this multiplicity. So yeah, these are just some key contributions and provocations from my thesis. I really, envisioned and hoped to advance qualitative and theory-driven and post-qualitative research approaches in pain, decentering these humanistic approaches in research. So really considering this material life of this, non-human bodies, these places, its objects, etc. Attention to power dynamics and their relation to knowledge systems. That these approaches are deeply relational as it recognizes reality as being shaped by human and non-human actors, and attune educators and learners to the biomedical discourse in the identity and culture of healthcare professionals, and also attune educators and learners to the social, material, cultural, and environmental forces entangled in everyday clinical practices. Yeah, I hope there was lots of food for thought for, concepts, ideas. I'm happy to hear your thoughts, and just this final provocation, what becoming a physio could look like in today's world. Just a reflection. So again, thank you so much for having me, and yeah, I'm happy to answer any questions or thoughts or reflections.
You must take on, Karime. Thank you very much